so thank you for coming on. I have Dr. Hilliard, and you are an internal medicine doctor, right?
That's right. And my sister's also a physician in the same area, so yeah, it's pretty neat. My dad's a cardiologist. He works with me currently. My sister is an obstetrician gynecologist, and she's not practicing clinical medicine anymore. But she's, once you have your credential, they don't take it away from you, no matter what you decide to do with it. So, and my mom's retired, so but she's a psychiatrist.
And you said your dad's practicing with you right now?
Yeah, he was retired for about 5 years, and so the type of practice that I have now, I'm an internist, but I also do preventive medicine, and so I engaged him to work with me with my practice to do some cardiovascular screening and cardiology evaluations for patients that come through our office. So yeah, he's working about 10 hours a week, and he enjoys it.
That's cool.
Yeah, it's fun.
That must be interesting, like growing up and then you end up working with your dad.
Yeah, it's really good. I mean, we've worked in the same community for a long time, and then he retired, and so it's exciting for him to come back to work. But also, I've never worked. My sister was part of this practice too, so it's the first time really working directly with my family, which has its challenges, but it's overall it's rewarding.
Yeah. I was going to ask you, if you look like you're in a private practice setting right now.
Yeah.
So I guess, how did you choose to be private practice as opposed to, I guess, being in the hospital as like a hospitalist, is that they would call it?
Yeah, I was a hospitalist when I first came out of training. I was a hospitalist and did outpatient. And that was during a time when there wasn't a clear division between inpatient docs and outpatient. That sort of movement happened probably around 10 to 15 years ago, where they did some studies and they showed that patients did better in and out of the hospital on discharge when they had dedicated physicians that were only inpatient based. So before that time, most docs in the community, like myself, took care of their own patients in the hospital. But what it meant was we worked all day in the clinic, went home at night, got called during the night to come admit patients in the hospital. We had to live when I was a hospitalist, my group would do, so it was a 5-person group. One person was on duty for the hospital for the week, and we'd just rotate. And during that week, I didn't see patients in the clinic because to round on all the hospital patients and get up in the middle of the night and things like that, it doesn't work well with having to work 8 to 5, every day. So after these studies were done showing that patients' hospital stays were shorter, they did better in the hospital, had less chance of readmission with having a dedicated physician in the hospital. These hospitalist programs started to come up where people were coming out of training just doing hospitalist care, which is like shift work. It's similar to ER medicine in that you work 7 to 7 and then you're off. You may work 3 days in a row and have 3 days off or something like that. So and then for a long time I was part of a medical group that had outpatient doctors and hospitalists in the same group, but there was no crossover. The hospitalists were always hospitalists, and the outpatient docs were really, although some of us still did some hospital admissions and took care of our patients in the hospital, we were encouraged to keep our practice all outpatient. And just make it cleaner. It's, patients don't care for it so much. It's like I still do courtesy visits on my patients.
Okay.
They have a hospitalist. We're right across the street my office is right across the street from a major hospital in our city. So I just walk across the street and I'll do courtesy rounds, where I'm not making the clinical decisions for their admission, but I still continue we want to have continuity so that they know that I'm on board with whatever's happening with them in the hospital. So I
Okay.
found that works really well. Yeah.
Okay, so even though you don't have the right to have clinical decision, really, in the
Mhm.
hospital, you're still showing, I guess it's a more just like showing your face, just to show
Yeah.
you're present, like in there and support.
Right. And at times I have had to intervene, if I don't think the right things are being done. I sometimes am coordinating their care sometimes they'll have four specialists seeing them in the hospital. Nobody's communicating very well. So I almost become the point person, for clinical decision making. And, some of the stuff is great in the hospital, but how do we manage it when they get out of the hospital and go home, medication wise, in terms of what kind of care they need after the hospital. A lot of times I'm involved with the case management team, helping the family to make decisions about what happens outside of the hospital. And the patients like it because it's not like they went to the hospital and they were totally out of your view.
Yeah. Yeah, I could
Uh,
see that. I could see how that would be like comforting and
yeah,
with that familiarity. You're the primary already.
yeah,
So
right.
I see. They feel cared for. That makes sense.
Yeah,
Um,
it helps. I'm not doing, I mean, it's not a lot of time that takes me to do it, but
mhm.
I think it's a value add in terms of the patients feeling like they're taken care of completely.
Yeah.
It's not care, especially these days, can become very fragmented and disjointed, where patients may see a cardiologist, an endocrinologist, they've got their primary care, internist, or family practice. They have a gastroenterologist, they have a psychiatrist.
Hmm.
Nobody communicates with each other, although we may even be on the same electronic medical record. That's helped a lot with communication. But often patients see a lot of specialists and nobody really communicates with each other about the plan. There's not a comprehensive type of decision making that goes on about patients. And
That's
that's
crazy.
what's different about my practice now, is that it's called comprehensive wellness, and we're really trying to go back to a more of an old fashioned type of care where, I mean, when I first went into practice in 2000, doctors used to, if they took care of your patient or had a consult with your patient, they'd call you up and they'd say, "Hey, I saw your patient. Let's talk
Right.
about it." But in this age of, it's all digital and, there's less communication in that way. And so for patients, they're almost like they can become more isolated and like an island, and all their specialists, where the patient actually has to communicate to each doctor what happened during their
Wait,
other
yeah,
visit. Although we should be able to integrate the information well, a lot of times it doesn't happen that way.
that's crazy to me. I always thought that that would make the most sense. Instead of
Mm.
going to each person like, okay, this is what I'm doing, these are the medications I'm taking. It should just
Yeah.
be, instead of having to take the patient's word for it every time or having to give that information to your doctor every time, it would make sense that everyone has access, under the right guidelines and everything, obviously, to that
Mhm.
information, so they're all on the same page. So that's crazy to me that that's not.
Yeah. And so we're on an electronic medical record that really it's pretty robust, in that most of the practices in this area are now on the same electronic record, which is great. And even though we're not Kaiser, we're loosely affiliated with UCSF, but I can see all those records too from my chart. So it definitely is all in one place. It's just, you can imagine how
Yeah,
big a system that is, and you actually have to know where to look for stuff.
yeah,
So, um,
like you said, comprehensive.
yeah.
That's
And
all.
in my practice, we have primary care. We also have gynecology. We have mental health services. We have psychology, psychiatry. We have an energy worker who works with us, so more on the holistic side. We have hypnotherapy. And then we have physical therapy, nutrition, cardiology, endocrinology. We have a weight management program. Um, And we have a nurse sort of care coordinator she has an outpatient nursing coordination group. So taking care of patients in assisted living and at home, and, that need more, even more help with coordinating their care between their different providers.
Okay.
So it's really good. I mean, we're still working toward it being more and more comprehensive, where we can have, care conferences every week on patients that we share.
Mm-hmm.
But it definitely, and our philosophy is to not limit the time that we spend with patients. We offer value-based care.
Mm-hmm.
Whereas the conventional medical system is going more toward more frequent doctor's visits, shorter visits. We don't think that really benefits the patient.
Yeah.
As much as if they could have 1 hour, however long it takes, an hour and a half long visit, to really get to the bottom of things, to do a full physical history, particularly with things that are on the emotional side.
Mm-hmm.
When I was part of another group where I was really pressed to see patients for just 10 minutes, and on to the next patient, and get to see 30 patients a day, I could take care of a patient for 10 years and not really learn very much about their social habits or their diet,
Right.
their relationships, things that were really important to them that you just don't get to after you do a greeting, which takes a couple of minutes, and then you talk about their blood pressure, and you talk about their labs, and you talk about their visits with their specialists. If you have 10 minutes, that's all you get to.
Mm-hmm.
And you don't have time to ask about how much they drink and how did they gain so much weight? What are they eating? What are they doing for stress management? Who's at home and are they getting along, right? Mm-hmm. So all of those factors, those are the ones that overall affect people's sense of well-being.
Yeah.
It's not necessarily the blood pressure it's an important thing. It's a silent killer, but people are really suffering from other stuff, isolation, especially during these times. I mean,
yeah.
Those kind of discussions are important. And the way conventional medicine is going, the direction it's going is to sort of fragment things further. And, we're pushing back a little bit against that. We're a little bit disruptive in that way.
Yeah.
But it's good. It's good for me.
Yeah, it seems like it's funny because we're now like 20 minutes in and I haven't even looked at my questions because I'm so interested in the internal medicine aspect and the preventative medicine, and then also how you've like bridged the gap with the holistic medicine and all that practice, and that's so interesting to me. And I feel like that's probably really rare, at least for me. I feel like I haven't seen too much of that. It's either you go and you get your what they call modern medicine, Western medicine, or you go and seek holistic treatments. But I like how they seem to be integrated, or there's options for both people. And so I guess I'm like curious now, like how do you guys like integrate the holistic and the Western medicine then? Like I don't know, how do you deal with both of those two aspects, two sides of the spectrum?
I mean, it's interesting. It's not that, I mean, you're right. I mean, I definitely, I'm an allopath. I'm trained in the Western sort of style or Western philosophy of medicine. So that's kind of my base. That's where I started. I wasn't trained much on nutrition or about energy or about the holistic side, but I've taken it upon myself to find out a lot and do my own training on those things because I realized how important it was for people's overall health. And I also know that certainly with not everywhere in the country, but in the area that I live in California, if you don't even entertain the thought of even talking about those things, the patients want to talk about it because it's popular out here. It's sort of
it's not everywhere.
if you don't want to talk about herbal supplements with patients, they'll move on to another doctor because that's just how they live out here, you know.
Oh, that's so
So
great.
that's good. It's good for me. I mean, I learned a lot. I had to take kind of a deep dive into it to learn more.
Mhm.
I was working and I didn't want to. I thought about going back and getting a degree or getting a specialized training in preventive medicine or in integrative medicine, but I felt like there was enough information out there that I could educate myself about it, about those things over whatever period of time, and continue to educate myself. Um, and so it's been part of the conversation I've had with people for a long time. But I decided to really shift my practice to do it, really wholeheartedly about 3 years ago. Mostly because I was being pushed I worked for a big medical group, and we're just getting more and more pressure to fragment the care, to create more visits, more short visits for patients, to not go in depth about, they can only talk about one medical problem when they come in, right? And so you create a short enough visit, you don't have enough time to deal with their overall health and everything that's going on. So I just that didn't agree with me. I knew I had to get out of that kind of care. But integrating it's tough at times because it's not that I am against medications or against diagnostic tests but I don't necessarily have the discussion about the holistic stuff with every patient because I try to gauge where they are.
Mm-hmm.
So if they're sort of heavily bought into their disease process as being from, stuff that happened to them and their heart disease just happened, right? It wasn't anything that they did that brought them to that point.
Yeah.
I mean, there's not much I can say or do to change their mind about that. So I don't spend time when I gauge that patients are not really that bought into talking about the holistic part. I generally don't try to just, force that onto them,
right.
Because I don't think that would waste their time and mine.
Right.
And it may destroy trust that they have in me. I do have training on the other side. I can up their blood pressure medications. I will always talk to them about diet, but if it's clear to me that they're not willing to make lifestyle changes and they just want to manage their heart disease and cholesterol with medications, statins and blood pressure medicines, I don't really try to fight against that because I also think if people don't have someone in their corner just to take care of them, that's a loss too.
Yeah.
I don't want to alienate any patient because I'm speaking a language they don't really want to speak, right? But often I have people that get into a real crisis with their health, and I see that as my biggest opportunity to help them make some lifestyle changes. I just break it down for them. The medical problems that we treat now are lifestyle related, just plain and simple.
Yeah.
In whatever system, whether it's lung disease, heart disease, gastrointestinal disease, all of it's been tied to our lifestyle choices, food that we eat, cigarettes that we smoke, environmental things that we have going on. Even mental health stuff. It's like the stress that we've created in our lives. We've overcomplicated our lives with too many things, too much attention to things that really we don't have any control over.
Right.
So for some people, they don't really open their eyes or open themselves to talking about integrating traditional medicine into their care, because they don't feel that bad. If they feel okay, medicines are working okay, why do I have to change anything about my lifestyle, right?
Yeah, I could see that perspective.
Yeah. So I'm not excited when people get really sick. It's not good for them, but I know it's like you got to strike while the iron's hot, right? So when they're really feeling bad and they want to know, they have the most opportunity for change. They're
Right.
desperate for it. They need to feel better. They want to live. It's like some people, you don't know if they really care that much about living until they really are faced with not living.
That makes
They
sense.
get serious about it. Oh, I was on the specialty track. My dad's a cardiologist, and I thought I would follow in his footsteps. And so I went to medical school, and then I in training, I was on there were two different tracks. There was the primary care track, and there was the specialty track, which got a lot of, you just did more rotations in ICU and CCU and less outpatient medicine rotations. So until my last the last third of my year of residency, my last year of residency, I had every intention of becoming a cardiology fellow. And then I got really interested in nephrology, and it sort of shook things up for me because I had never considered that. And then I thought I would do nephrology, and then I was really like feeling like I needed to have a life, even though I had been, I mean, you've been in medical school, you've been in college medical school, and then you're in residency. And so I thought I would take a year to think about if I wanted to go back into fellowship and just do primary care. So I did that. And I was a hospitalist that year too. And I decided I really liked it. So I decided not to go back and do further training.
Okay. That's nice.
It's interesting when you're doing primary care, you get to see, I also realized about myself that I like to do a little bit of everything. The challenge of being a generalist and not a specialist is that you have to know a lot about a lot of things. And, you don't know I don't know it in depth as much as a cardiologist knows about the heart, but heart disease is our number one killer. So it's like, it's inevitable that I have to know a lot about the heart. I have to know a lot about the gut. I have to know a lot about the lungs, the major internal organs. So I found it really interesting to not have to like silo myself into one field. For some people, they really like to really super specialize and focus like that. And I realize my personality is different than that. And then now through my career, I've also started doing aesthetic medicine. So I do that too. I've done that as part of my practice for about 15 years. So I do Botox and fillers, and the machine behind me is a skincare laser. So I do that too.
Okay.
And that's fun. And it keeps it light,
That's what I was gonna ask. It's just like, it's fun, something different, something new.
Yeah, and I even do the aesthetic stuff as more of a holistic approach too. I always talk to people come to me, we have a skincare line through my practice that we private label, and I've put it all together and picked products that can really help people to optimize their skin care. But I probably different than some plastic surgery practices or dermatology practices, I always talk about nutrition and lifestyle. Because how your skin looks, like it's a reflection of what's going on inside your body. If you're staying up all night, if you're drinking too much, if you're eating crappy food, your skin's going to show it.
Yeah.
If you're dehydrated, you have dark circles under your eyes, your skin shows it. You may look 10 years older than you are. And you'll be coming to me thinking I'm going to say the answer is filler, but I'll probably say the answer is nutrition. More plants, less meat. That's how
Is that what the patients want to hear? Or do they want that quick fix?
They may not expect it from me, Can you just put some filler under my eyes as a quick fix? And I say, I can, but it will be a partial fix, and it's not going to be what you want. Let's talk about your weight. Let's talk about your diet. It's hard. That's the hardest part about what I do. People are although they want to feel better, they definitely want to feel better. We've gotten into a time in our country where it's like the quick fix, the pill. Just give me a pill. Just give me a pill that's going to make it better. Well, that's not what it's about. It's what you put into your body and how you treat your body. Like if you need to move around, you need to exercise, you need to meditate, you need to reduce your stress. You need to put some of the news down, put the devices down. You don't need to be looking at stressful stuff all the time. You don't need to look at bad news all the time, because you can't help but absorb that into your psyche. It's just impossible to do that. You need to surround yourself with people that are like-minded. You need to stimulate your mind. I correct people sometimes when they say, oh, well, this holistic stuff, this new age stuff, oh, you're into that stuff. And I say, well, this stuff is really old stuff. It's like, right. This is the oldest stuff that's around. Like, just eat well, pray or meditate. It's like, that's the oldest stuff around. That's like getting back to our roots. That's what we used to do. Look at where you came, look at where your ancestors came from, and look at what they ate. Yeah. And I promise you, it was a lot of grain, a lot of vegetables, and then maybe a little bit of meat, if any meat at all. Right. So we can change what our health looks like in this country. We can change it through our diet. We can change it through our stress reduction. We can change it through exercise, and community. It's like, we don't do well isolated, and we need to be have community and have connection with other people. That's important. That's how people live longer, and live functional lives for longer. So I think we're all learning that now more than ever, that we need this connection. But it's been a long time coming with social media and everything else, just further isolating one another. People from each other. So I wish we could just eliminate all that, but that would be one of the get to a more simple time, right? Right. Yeah. I agree with you. And keep our circles smaller. It's not that you don't want to know what's going on around the world, but look at what you can control, and that's right around you, your community, your environment that's within reach of you. And then you feel more empowered, and then you don't feel small, and you don't feel as isolated, because you connect to what's right there next to you, and those people that are right near you. Right. So that's my thing. Okay. So I don't see really challenging medical stuff every day, because as in any specialty you go into, it's like you're gonna see mostly when you're in training. Like, I trained at a place that was it was the biggest medical center within 300 miles. So we got all the really hard, interesting cases. Like, we got soldiers that had come from abroad that had malaria. It's like, do I see that in my normal practice every day? No, but I saw a lot of really interesting disease processes when I was in residency. I still see some now, but it's not very often when you get a really complex thing, but it's exciting when it happens. So I've had a person recently, well, not that recently, but over the past couple of years, that had a really difficult to diagnose kind of mitochondrial disease, which they've been feeling really run down and fatigued and weak for years, and then they started having where their muscles were breaking down, and it was coming out through their urinary system. So they had rhabdomyolysis and had to go in the hospital. And so it's then it became evident it wasn't just, the person had gotten diagnosed, the woman had gotten diagnosed with, and a young woman, she was about 35 when this started, diagnosed with fibromyalgia and depression, and, oh, you're probably drinking too much, oh, you're this, oh, you're that, right? So, but sort of missing the mark, because it was a very rare disease that she had. She had a very rare mitochondrial condition that really could only be diagnosed by a muscle biopsy. And so it was pretty satisfying. Not that there was real frontline treatment for it, but just to know that, she was even convinced at one point that it was just in her head, that she was just making these symptoms up. Yeah. but it's pretty satisfying when you can get to the bottom of something that's rare. You know, you kind of go through the normal processes of diagnosis and you realize that you may be missing something. There's something that's not common. So you have to go further down that road.
Okay. And do you have to go back and, I guess, re-educate yourself on that then? Because you're not used to speaking.
Absolutely.
Of course. I think people think that doctors just graduate and then they have all this knowledge and that they don't have to. There's probably a misconception about, oh, I have to go refer to someone else, ask another
And all
doctor.
the information changes. Like when I finished residency, the study had just come out that hormones for menopausal women was risky, causes increased risk of heart disease, increased risk of breast cancer. For 15, 20 years before that time, all through my medical school, all through my medical training, it was like hormone was like the answer to everything. Risk-free, made you feel better, let's put it in the water, let's give it to everybody who's even, above age 40. Let's give it to every woman, until this big multi-center study came out right when I was finishing residency that showed, doesn't mean you can't give it, but it's risky. There's risk associated with it. So the medicine changes, the recommendations change. There's going to be a time, in our lifetime where they're going to say, can you actually believe they used to cut people open and do surgery? It's like,
Yeah.
They're almost there now with brain stuff. Like, why would you cut the skull open and open it up? Why would you do that? You can do it with targeted therapies. You can do it with radiation. So it's always changing. I look at my dad. It's like when he was in medical school, they hadn't even discovered like the genome. They didn't even know that they didn't know the structure of chromosomes or anything. It was like, that's all
Crazy.
Since he was, he graduated from medical school, I think in '68. So it's like so much has changed. If you looked at his textbook, they've discounted everything that he learned at that time. You have to be fluid.
Yeah.
If you're keeping yourself educated, then you can really mold your recommendations. And patients are really well educated now. That's what I'm finding, is they know when the recommendation changes for when you need a colonoscopy. My patients often tell me about those things before I have read it. Patients are way more educated about medical stuff than they were even when I first started practicing.
But that, I was going to ask you actually how you felt about patients going to the internet for diagnoses, and then later coming to you, I guess, with what they think is going on. Is that helpful, or is it hard for you to hear, oh, I went to WebMD, or I looked it up on the internet and I really think I have this? Or
it's not hard. I'm really used to it because it's been so much a part of my career. People have done that. The problem is that when people type in symptoms like that, it's always going to give them the worst case scenario. It'll also tell them the common thing that could cause that, but it's going to tell them, like, you have a headache, that you have a brain tumor. That's always been my differential. I always have that on my list of things it could be, but tension headaches are far more common. Migraines are more common. So, it's not that it doesn't really bother me anymore about, it's sometimes it does when they're really aggressive about it, like just insisting that they have this rare disease, which is not likely. They could be right. But I'm glad that there's educational stuff for patients. If they use the information or access the information correctly, they can really learn a lot and direct their own care. Most of the stuff that talks about, if people go and say, oh, well, I'm having a heart attack, or I have heart disease. It's like, if they looked at what the recommendations are, then they do know, and they also can look at the lifestyle modification stuff that's recommended. That's the part I struggle with getting people to look at, is not just the alarm stuff, but the practical stuff that they can do, for prevention.
Yeah.
But yeah, no, at times it is, when people bring in a list of that they've copied off of WebMD all the conditions that they think they have, it does become it becomes a game of just trying to convince them they don't have it when I really don't think they have it, you know.
Yeah.
But I'm not, I never, or I try not to discount what they're saying about it, because are those things in the differential? Absolutely.
Mhm.
With every headache, brain tumors in the differential. It's just not very likely, but it's always there. We just have to go down a road of trying to rule out things.
Mhm.
But diagnostic testing wise, it's like, you know, you don't want to, I don't want to get into a business of doing head CTs and brain MRIs on everybody who has a headache when it's not warranted, you know?
Yeah.
So, you know, it's a good question. It is a lot of what I do, is trying to convince people why I don't think they have something, right?
Yeah. I have just like 3 questions, or maybe it might be 2.
Okay.
I was wondering if you could speak to the unrealistic expectations that people have as a doctor, and what is something that someone wouldn't expect going into the medical field.
Oh, unrealistic expectations. People that are interested in becoming a doctor.
Yeah, who are interested in following that path.
It's not glamorous. It's very interesting, but so that sort of, and even I had this view, because even though my parents were doctors, I didn't see them in the office. It still looked very glamorous to me as a child and as a teenager, because of the lifestyle, you know. So they had enough money, they had a nice house, they had nice cars, you know, they had all the sort of external expressions of, you know, of wealth and well-being, right? But what I didn't realize until I was really in training, probably, was the amount of sacrifice, like especially if you're in a field where there's night call, you know, it's sort of like sacrifice not only to yourself, but if you have a family, you know. And then I thought about it with my dad worked really long hours. I didn't realize as a kid that it was the only thing I knew. I didn't know people's dads were home at 5 o'clock, right? Because my dad was working a lot. And people look at doctors and they think, oh, well, it's, you know, it must be glamorous to be, or must be, you know, most medicine is messier than I think people realize. It's you kind of get in the depth with people and how they really are. It's not pretty all the time. You can really see some tragic things. You hear some stories that you wish that you can't unhear, you wish you didn't have to hear. But it's very interesting. It's sort of interesting to have like you get a look into people's real lives, not what they want to show you, but the truth, right? So no matter how ugly, how dirty, how people don't want to tell you, and I push people to tell me the truth about it. Like I tell them, I've heard everything. Like, you will not shock me. There's no chance. I've heard every dirty, ugly, nasty, seen every nasty thing, smelled every nasty thing that could come out of a body. It's not glamorous, you know.
That's a very unique position to be in.
I feel privileged. I feel privileged to be there. I mean, I've been privileged to be there when babies were born, and I've been privileged to be there when people take their last breath, and it's profound. But I don't know that people realize, you know, the scope of that. Emotionally, it's not easy, you know, to sort of, you have to learn how to compartmentalize things a bit. You know, if you carried home so you're taking care of sick people. People are not at the doctor because some people are seeing me because they're just getting a well check, but for the most part, people are there because they don't feel well. And so you take on the emotion of that person. To be a good doctor, you have to be empathic and be open. but how do you do that and then close things up to go into your own life?
Right.
You know, how do you like, why did I spent a lot of time devoted to my training and my career, and I didn't have much time to have my own relationships or have my own family. I mean, I had my son when I was 47, and most people their kids are in college by the time they're that age, right? So, so there's some sacrifice there that a lot of, people don't talk about that side of being being a woman in medicine, right?
Yeah.
There's sacrifice there. And they won't necessarily teach you that in medical school. They don't teach you the economics of medicine. They don't teach you the business of medicine. You think I'm going to roll out, I'm going to make a ton of money, and I'm going to have it all together, and I'm going to have 3 kids, and I'm going to take care of all that and work. And it's tricky. A lot of people choose primary care. There were some people that had kids when they were in residency with me, had babies when they were in residency, and they choose a career path based on wanting to be with their family more.
To have the work-life balance.
Say it again?
I said to have the work-life balance.
Yeah, it's really, my sister's OB/GYN. It's like no one ever talked to her about the work-life balance. She's in training. She's really interested in OB. Those middle night calls when somebody's pushing a baby, I'm telling you, that is not easy.
Yeah.
It is very challenging. People burn out within about 5 years if they don't start to put some boundaries there. Or most docs that do OB/GYN don't do the OB part for their full career because it just takes a toll. It's like some people have to make a decision. Either I'm married and divorced 3 times, or I pay some attention to the work-life balance, right? So, but people don't really, I don't know that it's much different in training. You don't get a lot of coaching or training around that stuff. You get a lot of training around the medical science and the medical stuff, but not the lifestyle stuff. I would tell people, if you love medicine, want a nice lifestyle too, dermatology, ophthalmology, those are great professions that there are never any real emergencies. They won't have to get up in the middle of the night for that. That's part of the reason why I got out of being a hospitalist. It's like, I did it when I was working up near UC Davis in Davis, California. And, imagine you're tucked in your bed, and you get a call to go to the ER to put a tube in to help someone breathe that's just a college student that's just drunk too much, and their friends just dropped them off at the door to the ER. They didn't even care enough to stay with them, right?
Yeah.
So you put a tube in, you help them breathe, you save their life, and the next morning they don't appreciate it at all. They just want to know when you're going to take it out so they can go home, because they don't remember what happened because they were drunk.
Right.
So it was only a certain amount of time I could do that, where people would just, they would be screaming at me, "Can't you let me out of here? Why haven't you let me go home?" And it's like, I just saved your life. A thank you would be nice, but so that's the part, it's like it's not glamorous. It's not always fun. It's not always interesting either. There's a lot of just regular coughs, colds. I mean, I know you're thinking about gastroenterology, right?
Yeah, general internal medicine, preventative medicine, honestly.
Yeah. You have to be an internist first to be a gastroenterologist, so that's the path. But the GI doctors would probably say, you get a few interesting stuff. You get a lot of just benign polyps, and you get a lot of people coming in for diarrhea that you don't know, other than their diet. Like, stop eating so much crap, and your stools will be better, But it's some of the same stuff I deal with. If people would take better care of themselves, it would be easier. But
yeah,
we're here for them. It's like, also if people took excellent care of themselves, they wouldn't need a doctor.
So I wanted to touch on feeling, if you felt any imposter syndrome being an African American professional, and if you questioned your worthiness during the process of going through medical school and
Mhm.
residency, or if you felt others were questioning your place.
Um, well, I think because of growing up in the family that I did, and even with your grandparents, they were a big part of my life too, and they were physicians. So a lot of my circle was with people that were professionals. And so I think my brother and I were just talking about this, how although we had some people around us that were like-minded and like us, it actually is quite isolated. It can be a quite isolating experience to sort of be a Black doctor. And I don't really know if I know how people feel about me, or whether they think that I'm worthy of my position or whatever. It's almost all I've known, and it probably has to do with if I were first generation physician, I probably would feel more of that. I'm third generation. My grandfather was a doctor.
Yeah.
It makes a huge difference. Many people around me were doing this. I didn't feel, I know with some people that I trained with, they were the first person in their family even to go to college. And so they definitely felt like a stranger in that world. And so that experience was different than my experience. The thing that I think I felt more of is this kind of isolation where you don't, because of how I grew up, because of how I definitely had strong Black influences in my family, but I also was raised going to schools where there were a lot of white people, mostly white people. People didn't look like me. So it became evident to me from grade school time that I was different. And you're isolated. You don't realize over time that long-term kind of isolation, you don't really, which group do you fit into? You're not white. You're clearly not white because you don't have white skin. You have a strong Black family and Black heritage that you know about. You're not denying any of that stuff. You're proud of it. To much of the Black community, you're not Black either. Especially the higher you get in your education and your profession, you definitely aren't part of that group anymore. Not that whole group, not the larger group, right?
That's how how you're perceived.
Perceived, right? But you perceive yourself that way. It's like, where do I fit in? Which group am I part of? Am I part of either group? And I've talked to other people that grew up the same way and have, even if they didn't grow up that way, once they graduate from college, you're in a different sort of set, right? And then if you go to medical school, it's like you get more and more isolated in that way. You can. Where it's difficult to see where your group is. And even sometimes I've felt like I was accepted by a certain group, but it became clear to me that they saw me very differently than I saw myself in that group, right? But yeah, I think the isolation part, it's difficult. It may be, they've done studies on this showing that people that have isolation from groups that are around them may suffer like a syndrome of somebody that has long-term trauma, right? Not the big trauma, not like major crisis, but long-term struggles with interacting in relationships with other people because of that, right?
Last question is if you have any good books related to medicine or any other anything else that you would recommend someone to read.
So one that I really like right now, I have a lot of books I've read and things that I am interested in, but it sounds morbid, but there's a book called How Not to Die.
Okay.
And it really talks about plant-based diet and the evidence for, sort of changing what we put into our bodies and how we can provide our bodies with more micronutrients.
Okay.
That's been the one I've been talking about probably for the past couple of years.
Oh,
The most,
okay. Okay.
because I don't know. I don't like to use scare tactics with people all the time, but when people really, when I find that they, have something that happens that makes them really frightened about their health, I want to sort of use that moment and use that opportunity to get them to engage in a different way. So I don't know. That's the one I can think of right now.
Okay, well, yeah, definitely. I mean, I love to read new things, and I feel like there's that absence of medical recommendations, like books related to medicine and health. And I'm always like, where are these books? And then I find some, well, that seems a little stiff, or,
Yeah.
but I'm very open to reading, and I think more people would be too. So I'm definitely gonna
Check
add.
that one out. I think you'll like it. And it's most of it, like a third of the book is it's the notes section, and it's all the reference papers. That's what I find really interesting, because everything he cites in the book, he gives the reference, and then there's all these papers and all these studies that were done, and that's where I can just dive into all of that. Everything I'm like, oh, well, I want to read that, so I'll go and read that paper.
Based. It's like
It's so great. It's like, how are mood affected by our diet? Like all these papers that he lists on how our mood's affected by our diet and our lifestyle. So, how's our gut health controlled by that? Our gut flora gets totally like processed foods. We think we're eating healthy because we're not eating a lot of carbs, but
yeah,
the right things to keep the right balance in your body. And then the gut kind of controls everything.
Yeah.
It does. If your gut flora is off, you're depressed.
I've definitely heard that.
All over. You're bloated. You can't lose weight. You gain weight. You are irritable.
Mm-hmm.
You can't sleep. And it has to do with balance, and you're sort of the balance of microbes in your gut and the balance of chemicals and nutrients in your body.
Yeah,
that's what I found.
Yeah,
we have medicines to treat everything, but it's like I don't want people to have a lifetime being tied to a pharmacy.
Yeah,
that's more like being on earth. That's no fun when you got to call your doctor every 90 days to get a refill. Not fun. Do you have many friends and stuff that are vegan and that kind of stuff, or what are you guys talking about?
I do, actually. One of my closest friends is vegan. A few of my friends were vegan. And
environmental reasons or for health reasons?
I think for both, honestly. And I was pescatarian for 2 years, and then I went to college, and that lifestyle was hard to keep up at the cafeteria food. But I want to go back to it. I still don't eat a lot of it myself, but I would love to be like a fully Mediterranean diet. They say that's like the best one for you. So.
And then flexitarian came in the early 2000s. It didn't really catch on.
I've never heard that.
Huh? Never heard it? Vegans and vegetarians don't really like it because it's basically you don't eat any meat, eggs, fish, or milk products for 5 days a week, but you have those things a couple days a week, and then you're officially flex, which.
Thank you so much, by the way. I really enjoyed this.
It was fun.
Yeah.